Thanks so much, Viet. EM has a question. Her question is, how is urine sample from someone with spinal cord injury typically done in the community? Presuming you aren't doing a urinalysis in asymptomatic patients, basically the decision to treat is based on a presence of NITS, HB, and then positive or minus increase in Lukes versus baseline, since they will all be bacteriuric chronically. I always struggle with antibiotic stewardship versus not missing the boat. Like, did you not sleep well, or is this a UTI, or is it a cold, or is it a UTI?
No, you are not doing urinalysis on asymptomatic patients. The decision to treat is based on the symptoms and the urinalysis. Because nitrites can sometimes be negative, even hemoglobin could be negative. So it comes down to leukocyte esterase and pyuria and the symptomatology.
Yeah, I mean, I guess like the thing is that it could always be a UTI because the symptoms could be so vague and they're always going to have bacteria in their urine. So I'm like constantly getting calls. I have a particular patient I'm thinking of who resides in long-term care, and like the long-term care nurse is like, you know, it's raining outside, we better do a urinalysis or like whatever. And she's got the added complication of having ESBL E. coli, so she's like
Colonized.
yeah, well, but yeah, so treating her requires inpatient, like move to hospital because you can't just give her oral antibiotics.
Yeah.
So I'm like forever saying like, let's just give this a day, let's just wait this out, blah blah blah. Because she sort of always seems to have Lukes in her urine, and she always has bacteria in her urine, and always will because she's got the chronic indwelling catheter.
I would suggest going one step upstream and just making sure that the nurses are changing. I'm assuming she has an indwelling catheter of some sort.
Yeah, it's a suprapubic though, so the nurses are. It depends on the nurse you get.
Oh, it shouldn't. Unless it was just changed within the last 24 hours, she will need a clean sample unless they insert a catheter through the urethra to get a clean catch. But anything from the existing catheter is going to grow a gazillion of everything. So
Yeah,
you'll get a
exactly.
mixed flora, which is not helpful. Then you're just, then it's all just empiric treatment.
I guess I hadn't thought about doing the clean catch through the urethra with leaving the suprapubic in place. That's a very smart idea. Thank you.
You're welcome. And, my take, what I tell the residents is my go-to is amoxiclav, just because, unless they have a penicillin allergy, but that's, fairly broad based treatment. And then I reserve the Cipro for really complicated UTIs because it's such a good antibiotic. I don't want people to become resistant to it. Septra I try to avoid because people have, unknown sulfa allergies. But again, it really depends on the culture and sensitivities. That's why it's really important to get all three, the urinalysis, culture, and sensitivities. And then you could give the prescription for antibiotics afterwards.
Viet, sorry, and you and I have had those discussions where you really emphasized the sequencing and how important it is to get the sample.
You don't want antibiotics on board. People used to take macrobid as a prophylaxis, and they swear by it when it works, but then it really muddies the results of the urinalysis and culture. So we don't recommend that either. And then, macrobid is not benign. Long-term use of macrobid can lead to pulmonary fibrosis, and we don't want that in like a tetraplegic patient who already has restrictive lung disease. Okay, I'll share my special request with micro. I usually call micro up and say, can you check if it's sensitive to fosfomycin? And fosfomycin is a really good one that I reserve for Proteus especially. And it's not a one-time shot for simple cystitis. It's a 3 dose, but it's every other day, 3 grams every other day. So it's almost like a total of 7 days of treatment.
Dr. Beamish, can you unmute?
So my question is the minimum number of colony forming units to diagnose a UTI, is the threshold higher in a spinal cord injured patient versus the general population, or is it the same?
I use 100 million CFUs per mil because I think the idea is that we know they're colonized, right? But again, if they're symptomatic and it's 80 million, I'd still treat. And then Keflex, I think Keflex doesn't cover gram negatives as well as compared to amoxiclav, but don't quote me on that. I just don't tend to use Keflex, and I'm looking at Dr. Townsend, who's shaking her head. Yeah, we don't use Keflex. That's more of a superficial skin treatment in my mind.
Okay, that's very fair. I think I just saw on your sensitivities there that it was sensitive to cefazolin, so ANSEF. But in any case, I was just curious because it seems like, we're waiting for these systemic symptoms to manifest, fevers or chills or abdominal pain or sweats and this type of thing, autonomic dysregulation, in the spinal cord injury patient. Are we, and obviously we're not treating the asymptomatic bacteriuria, as you made clear, which is great. But are we like just somehow missing then, in a large number of cases, the in between situation, like a bladder infection before it gets to become a more systemic, like
ILO?
kidney
Yeah.
infection or urosepsis or
Yeah, welcome to my world because it's, these folks, I would say like almost 100% of folks at GF Strong will have a urinary tract infection, right? And so their exposure to antibiotics is insane. We do want to minimize the antibiotic exposure, but then people become septic bacteremic pylo in like 4 hours. So really, it's based on the symptomatology. I think folks in the community know how bad it is, and they'll say, I'm going to ride this out or try to flush it out. I'm going to load up on my vitamin C. They've got lots of tricks and tips to avoid taking antibiotics. Back during training, I was taught to flush with antibiotics into the bladder, and now we're not taught that anymore. So I think some folks in the community still practice that, and it does stave off the UTIs.
Okay. And do other simpler things like drinking more water, hydration, or cranberry juice or this type of cranberry pills?
Yeah.
Anything like that?
The Canadian Nursing Association dispelled the cranberry myth. So that's not recommended anymore. But again, some people swear by it. I'm not going to discourage them. I would encourage cranberry supplements over juice to avoid the sugar intake. But people take vitamin C. Some people do D-mannose. Some people do apple cider vinegar as ways to acidify their urine. There isn't great evidence. There isn't
Fair
great
enough.
evidence.
Thank you so much. That's super helpful. Thank you.
You're welcome.
Dr. Vu, thank you very much for this excellent and comprehensive presentation.
Thank you.
I have a question about bladder stones. Typically, will they be symptomatic, increased spasticity, change in bladder function?
Yes, to all of those, because I think if you're a stone former, it just becomes problematic. I recently had a young patient who drank a ton of water. It wasn't his problem. He just formed lots of stones, and it would block the Foley. There's eyelets at the end of the Foley catheter. It would block it. And when we sent him to urology to do a cystoscopy, he had so many stones, he had to come back for a second procedure to collect all of the stones. So you could imagine all the different size stones will block the eyelets of the catheter. No one's really figured out who are the stone formers and if they could change their diets. We went through avoid nut milk because it can be an oxalate producer. And mom was really diligent, but he was infection after infection because he is just a constant stone former.
So typically it divides out into stone formers or non-stone formers. So if somebody's hasn't had evidence of stones for many years, it would be unlikely that they would
typically, yeah, they would present themselves pretty early. I think the young guys too generally have hypercalcemia, and that could lead to stone formation. In the beginning, it does level off in time.
That's good to know. Thank you.
Okay.
We've got another question from Astrid. She says, is it possible for a person with incomplete tetraplegia to regain bladder function? Is it common or is it rare?
I took this out, Astrid, because I was trying to shorten my talk. There is a prognostication for incomplete tetras. When we're talking about incomplete tetras, I'm thinking of the patients with central cord. They have really impaired hand function, but good leg function. And the idea is if they're the nerves in the lumbar spine, if you could picture the spinal cord, and then the lumbar nerves, and then the sacral nerves below. So a multi-center, like European study, looked at the lower extremity motor score. So, manual muscle testing of the legs. If they generally have 4s and 5s, that's a good indication of possible bladder function recovery. So that's when we would do something called a trial to void and see if they can urinate. But yeah, thank you for that question.
I had a question, Viet, if you don't mind. You and I have talked a bunch about this, but if you could tell GPs what is it that they can do to best interact with the system and sort of help physiatrists as well as helping their patients. Like, what are your number one recommendations for GPs in primary care?
I think if we're focused on the bladder, just definitely make the referral to urology. And I totally understand that not all urologists like or practice neurogenic bladder management. I've had to really make a case for a patient in the interior that he needed a urodynamic study. If somebody comes to you, a quick question is, when was your last urology visit? And they say, I don't remember. That would be a good time to refer them to urology. If you're in the lower mainland, the Blessin Spinal Cord Center has urologists who focus on spinal cord injury and neurogenic bladder. We do have lists throughout the province of urologists who do even intravesical Botox, urodynamics, and cystoscopies. That should be standard fare for urology. And everyone should have access to a urologist, although they do need a referral from their practitioners.
Andrea has a question.
I just thought you might want to comment on the annual creatinine and how a low creatinine is normal and even a below normal creatinine is normal, and as soon as it's creeping up.
Thank you. Yeah. So we do check creatinine every year, and you just have to, I think we just accept that it's going to be normal and low normal in the tetraplegic patients. But it's not really just that one snapshot. We're trending this, right? Like, you want to trend it just annually to see if it increases over time, and that's when that should raise suspicion. Otherwise, there really isn't a great, again, and then we follow eGFR, creatinine, and hopefully we could start testing cystatin C. It should be relatively easy.
Does the delta creatinine make a difference? So if someone has been chronically low for a long time and then comes into what would be considered a normal range for them, but is, let's say
Exactly.
20 or 30% higher than their normal, like, are they considered, like, do I need to start renally dosing their meds now, or do I still use normal eGFRs for that?
You're killing me. No, there is no published delta that we are aware of. It's just monitoring if there is a delta. It basically an increase. But again, I'm hoping that it's the full picture of renal ultrasound to make sure. You're kind of late to the game if the renal ultrasound shows up with hydronephrosis, right? So then the cystoscopy, just because we cannot see inside the bladder, and then the urodynamics, just to maintain that we know that the bladder pressures are okay. Because it could be elevated at 60 centimeters of water, but if it's been like that for years and years, they may not have to change their bladder management. But all of a sudden, in the course of 3 years, their bladder pressures have gone from 40 to now 100. We really have to encourage them to change their bladder management. So it's the whole picture, not just creatinine.
So, Dr. Vu, I have one last question if we have a few minutes here. I hadn't heard previously about the concerns with the condom catheter. And so I have a friend in town here who had his spinal cord injury 10 years ahead of mine. He's a complete C5, and he's been using condom catheter essentially 25 years. He has he's somebody who doesn't access the system much at all. So he's had really no follow-up. I don't really even know if he's had creatinines checked. Basically, if he's doing well, would there be any reason for him to change?
I think what you haven't told me is if he's had a sphincterotomy in order to use the condom catheter.
So I don't think so. When you mentioned that, that's a question I will ask him.
Yeah, and how many sphincterotomies has he had? Because it wouldn't be unusual. I would say like once or twice a year, I have this conversation with somebody who's an old timer, has been using condoms forever, and we talk them into getting a urodynamic study, and their detrusor pressures are 80. But they've just been living like that. Again, it's hard to say what the change is if they've been living at 80 for years. I don't know if the urologist or even myself would impress on them to change, but it's a very fine threshold, right? It's a slippery slope when that 80 becomes 100 and now you have hydronephrosis. So ask your friend if he's had a sphincterotomy. I'm curious.
Thank you.
Thank you everyone for coming to the Primary Care Spinal Cord Injury Lecture Series.